Any other announcements?
There's a little like club fair situation happening in Sommer tomorrow afternoon. It's gonna be fun. There's like crafts and stuff. Come on in.
Anything else? Okay, so with that, it's my pleasure to introduce today's speaker. Today we're going to be hearing from Erica. Erica is a veterinarian who has gone back to get her PhD. I was very excited that she said she'd be willing to speak to us today because I know there's a number of people in the crowd that, yes, are interested in veterinary science, but also interested in research. And of course, her research is on joint health, so even the human people that are interested in athletic training and such like that might also find this pretty interesting. And so Erica will stay a little bit afterwards as well if you want to talk with her and chat a little bit with her. But with that, I'll turn it over to you. I'm really excited.
Awesome. Thank you so much, and thank you guys for having me. I'm really excited to be here, and feel free to pause while we're chatting if you guys have any questions. And like Lindsay said, I'm happy to stick around afterwards, and I've got my email at the end. So if any questions come up later on, you guys are more than welcome to email me. So today I'm going to share kind of a little bit of how I got here, but a little bit about my research as well, which is kind of focused on the immune system in osteoarthritis. And myself as a clinician scientist, I'm really interested in taking this from the horse to the lab and then back again ultimately. So kind of share some of how we do that. So just a little bit of background of how I got here, how you kind of, get to the point of working on a third degree and not having a real job quite yet. So I was one of those typical little kids, grew up with horses, grew up riding, was determined I was going to be a horse trainer for the rest of my life. And a very wise woman who taught me about everything I know about horses said, "You're too smart to spend the rest of your life falling off of horses." She was married to an equine vet. She's like, go see some cases with the vet, see how you think, how you like that. And from day one, I was hooked. It was one day, and I'm like, nope, scrap that plan, going to vet school. So I started riding around with him a little bit, and then started volunteering in a small animal clinic as well to see, okay, I know I want to do vet med. Let's explore all the avenues. Realized I hate grumpy cats, hate them. So I'm like, okay, small animal is out. But during my time in small animal, realized that I really liked surgery. So I'm like, okay, large animal, but we're going to do a surgery track. So I visited Cornell in Ithaca. I fell in love with Ithaca, so decided to go there for undergrad, and then ended up staying there for vet school. And when I got there for my undergraduate, I was like, well, I really want to, go to vet school. I've done a little bit of volunteering, but kind of wanted to bulk up my resume a little bit for vet school applications. I'm like, well, I've got the vet school here. I'm going to just cold email a bunch of equine research labs at the vet school and see if I can try to do a little bit of research. Not really anticipating that I'd like it all that much, but honestly, just to bulk up my resume. Ended up falling in love with it. So I did undergraduate research, stayed there for vet school, stayed with the same lab through most of undergrad and through vet school, but kind of dabbled in a few different labs in vet school, and knew that I wanted to do a residency. So bounced around the country a little bit. I did a year internship in New Hampshire, did a surgery residency, large animal surgery in Illinois, and then spent about 4 years in private practice in Wisconsin and Rhode Island. And, I kind of had planned on PhD after residency. I was kind of burnt out with academia after residency, so I'm like, I'm just going to go be a surgeon, go be a doctor for a little bit. But as I think a lot of us, COVID hit, and I kind of reevaluated my life choices and things like that and what made me happy. And I love treating horses. I love fixing horses. But so much of what I was doing was putting a Band-Aid on the problem, and then I'd see them back in 6 months for the same problem. I knew I liked research. I had kind of always planned on a PhD, and life happens. It didn't happen, right afterwards. So I'm like, you know what? Great time to go back. So here I am back again for a third degree. And at some point I'll have a real job again, but I really like being a student. So I study the immune system in osteoarthritis. So when I say, what do you think of when you think about the immune system? What do you think about? immune cells? What do you think? Anyone? Yeah, white blood cells. What are they doing? Like, what is one thing, like if you're thinking about the immune system, what is like kind of one thing that comes to mind? Pathogens, exactly. That's where everyone's mind goes when, you know, you think immune system. You think, okay, I've got the flu, my white blood cells are doing their thing, I feel better in days. But one thing that we've really just started to come to learn is how much the immune system plays a role in everything. So maintaining our normal tissues, our normal joints, our normal skin flora. And this is kind of an area of active research. So this is just kind of a diagram of just one type of immune cell, so macrophages. And we'll talk a bunch about macrophages today. They're one of my favorites. These are just tissue-resident macrophages. So these are macrophages, so a type of white blood cell, that are hanging out in our tissues. And not only are they surveilling for pathogens and dealing with them when they come about, but they're secreting proteins that are essential for just normal tissue maintenance. They're protecting our blood vessels in the heart. They are kind of recycling proteins in our lungs. They're resorbing bone and helping to lay down new bone to help maintain our bone health. So this is kind of an up-and-coming, you can see this paper is just from this year. This is a very up-and-coming kind of area of research where the immune system in health and non-infectious disease is really kind of starting to come about and get learned more about. So I study particularly the immune system in joints. So with joints, we've kind of got a bunch of different layers. When we think about arthritis, we oftentimes think about just the cartilage layer. The cartilage gets damaged, it gets thinner, we get, you know, our bones rubbing together and get pain. But there's so many other tissues in addition to that articular cartilage that play a role both in normal joint health and then when it's diseased. So I, in particular, I oftentimes study the fluid that's kind of within this joint space. So we call it synovial fluid. And then the synovial membrane, or the joint capsule. And both of those, that fluid and that joint capsule, play key roles in, again, kind of maintaining our normal, happy, healthy joints, as well as when a joint becomes injured and develops osteoarthritis. So in normal joints, we have this layer of macrophages that normally sit on the inside of that joint surface. And those macrophages release a bunch of different proteins into the joint fluid, into the surrounding kind of space within that synovial membrane that not only kind of help kind of maintain like a homeostatic kind of immune barrier, but even help provide lubrication to the joint. And we all know how important that is. And when these, you know, systems kind of go awry, not only do these macrophages kind of change, but we can get other different cell types in there. And this balance between kind of normal homeostasis and then these more kind of pro-inflammatory conditions, we kind of lose that balance, and that's when disease develops. So I, in particular, study joints in horses. So who cares about horses? I mean, I'm assuming a lot of you guys care about, you know, veterinary species and stuff. But a lot of people would say, you know, right, ultimately, the human market is where the money's at. So who cares about horses? Well, the horse industry contributes quite a large amount to the US economy annually. Osteoarthritis is the cause of the majority of lameness in our equine species. And no matter what you think about the racehorse industry, you know, pros, cons, whatever, osteoarthritis affects horses of all breeds, all ages, all disciplines. So this isn't just, you know, the elite athletes that we're worrying about. This is all of the horses out there. Now, okay, so say you really don't care about horses. I'll judge you a little bit, but say you really don't care about horses. Who here has a grandparent, a parent themselves that suffers from osteoarthritis? Yeah, pretty much everyone, right? We all know people that suffer with osteoarthritis. Over 50% of people that are 65 and older have doctor-diagnosed osteoarthritis. So those numbers are actually probably on the low side, right? The number of people that have osteoarthritis that isn't doctor diagnosed is probably much higher than that. Studying disease in people is very tricky. So particularly when it comes to osteoarthritis, most of the human literature out there is based on people getting joint replacements. So those are the tissues that we can get access to, right? We're not going around and asking people for their normal, happy, healthy knees to study. So most of the joints that we get to study human osteoarthritis are end-stage arthritis. These are bone on bone. This is as bad as it gets, right? The problem with osteoarthritis is once joints get to that stage, we have lost the battle. No one has been able to figure out how to replace or kind of replicate that normal articular cartilage. So once we get to the point where that articular cartilage is damaged or gone, we're down to symptomatic management at that point. We've lost the battle. So a lot of this human literature, we're only capturing the cases that are well beyond the point where we can have any meaningful intervention. Another big problem with kind of the, studying the human side is healthy controls. So a lot of times the healthy controls that people talk about in the literature are people with rheumatoid arthritis or the contralateral knee in a person getting a joint replacement, which, let's be honest, probably isn't normal, right? So we use horses as a model for studying human osteoarthritis. Horses are a really great model for kind of extrapolating to the human side. They've got similar cartilage thickness and joint loading to human knee cartilage, and certainly human knees are far and away the most common osteoarthritic joint. Horses get spontaneous and naturally occurring osteoarthritis in very similar manners. We do a lot of the same imaging. We do radiographs. We use arthroscopy, and I've got a couple of arthroscopy pictures at the end that we can evaluate these joints in very similar manners that they do in people. And samples can be obtained from healthy and osteoarthritic joints. Thankfully, most of my research horses, for the cost of a carrot and a little bit of sedation, they really could care less which joints that I tap. So it's very easy to get really, truly healthy comparisons. And the amount of fluid that you can get is, let's just say that the mouse researchers, when I'm at conferences, are always very jealous when I talk about how much synovial fluid I can get from these horses. So even if you don't care about studying arthritis in horses, there's huge caveats to why we use these guys as a model species for ultimately studying human osteoarthritis. And several of my collaborator labs are physicians who care about the human side. So now to get in a little bit to kind of what I study. So I'm quite interested in the immune system. That was my undergraduate research. My undergrad research was the immune system in foals. Don't hate me, I hate foals. But I really do like the immune system. So to be able to take that into kind of more of a surgical sports medicine type of problem was quite interesting to me. But again, ultimately, I care about what I can eventually bring back and treat my patients with. So to do this, one part of a PhD is learning how to navigate. There's so many different methods and so many different ways to kind of go about answering a particular research question, and figuring out the best kind of series of experiments and the best methods for answering a particular question is a big part of it. So I like to say that I'm kind of taking my research from the barn to the bench and then back again. So I'm starting to try to answer this question of what is our immune system doing in equine osteoarthritic joints by looking at horses with naturally occurring osteoarthritis. And in looking at these horses, we can get an idea of what might be some of the changes in the completely naive, this is what's happening in the actual horse osteoarthritis. So one of my kind of aims of my PhD is studying the protein milieu, the protein environment in horses with osteoarthritis. So here we've got kind of our healthy and osteoarthritic sides of a joint. So again, a lot of people tend to focus on the articular cartilage. The articular cartilage is important, don't get me wrong, but there's actually very few cells that kind of change in the articular cartilage. They mostly just die. But the synovial fluid and the synovial membrane can be really important and productive kind of tissues and fluids within an osteoarthritic joint. In particular, the synovial fluid, because it kind of bathes all of the surfaces of these joints, the molecular kind of signal within that synovial fluid can change quite a bit and can change quite early in disease. So within this synovial fluid, people have looked at, lipids, metabolites. I, in particular, am interested in looking at the protein makeup of this synovial fluid and how it might change between healthy and osteoarthritic joints, particularly early in disease, well before we've got, radiographic signs. And at the point where these horses are still, they're not super lame, they're kind of on and off, it's more a poor performance thing. Those are going to be the times where we can have the most kind of bang for our buck in terms of preventing continuing disease from going. So to get a better idea of what might be going on with, or how we can use this protein environment to help aid in diagnosis and help find therapeutic targets as well, I've used a proteomics approach. So one big problem with studying horses is a lot of our immunoassays use antibodies specific for particular proteins to be able to measure them. If you're doing research in humans, rats, or mice, you can find antibodies for anything you want, absolutely anything you want. When you study horses, you have to get a little bit more creative because, again, people don't care quite as much about horses. So the nice thing with this proteomics approach using mass spectrometry is there's no need for antibodies. So we can go in with not needing anything that's specific for equine proteins. We can go in without needing specific targets to look at. We just put osteoarthritic and healthy samples into the mass spec and say, tell me what's different between these, and it'll pick up all the proteins in there. So we get a very large, a very untargeted data set. So this is actually a really good method for essentially developing hypotheses. And this is now used it's really kind of gotten popular in the last probably 5 to 10 years. It's a pretty new kind of method that's gone through a lot of development in the last 5 or 10 years. And it's used in a variety of species. Very little at this point in horses. There's one other group that's kind of looked at proteomics data sets in osteoarthritic joints in horses, but it's a very useful technique. So for this, I took joint fluid from horses with naturally occurring osteoarthritis that came in through the clinic. We had 8 healthy and 8 with osteoarthritis that we did proteomics on. And then with that proteomics data set, we were able to measure a couple of those proteins in a larger cohort of horses to make sure that our proteomics results, carried over to a bigger group. So this is some of the results that we had from our proteomics. So the red ones on the right are proteins that were increased in our osteoarthritic synovial fluid. Ones on the right in blue were decreased in our osteoarthritic synovial fluid. So overall, we identified 119 proteins, 14 of which were increased in osteoarthritis and 18 of which were decreased in osteoarthritis. So some of these are proteins that are commonly associated with joint disease and with osteoarthritis. So some things like aggrecan, cartilage oligomeric protein. So some of these were not necessarily new. We kind of expected them to be there. But the really cool thing with these proteomics approaches is we can identify proteins that are differentially abundant in osteoarthritis that we wouldn't even know to look for. So things like pregnancy zone protein, alpha-2 macroglobulin, both of these are potent anti-inflammatory proteins, which is interesting because they're very highly upregulated in osteoarthritic joints. And you would think anti-inflammatory proteins should be decreased in a joint that's inflamed, right? And what we're not sure is are these increased because the body is saying, okay, my joint's inflamed, I need to produce more, but they're not able to overcome that inflammation? Or is their function not quite up to snuff? And that's still, we're still trying to figure that out. Another one that our lab is quite interested in is lubricin. And lubricin is, not only does it have lubrication effects in the joint, but it's also anti-inflammatory. So we're quite interested in lubricin as well. So we're going to kind of skip ahead a little bit. So we kind of got our big data set. And now we're like, okay, let's see if we can pick out a couple of these to measure in a bigger group of horses, make sure that our proteomics results kind of, stand up to a bigger cohort. So of our 120 proteins, 2 we can measure in the horse using antibodies. So we're pretty limited. But 2 of those are lubricin and gelsolin. So lubricin was increased in osteoarthritis, gelsolin was decreased in osteoarthritis. We also added in prostaglandin E2, and PGE2 is one of these kind of gold standard kind of inflammatory markers. It doesn't show up on our proteomics because it's actually a lipid. When you take ibuprofen, PGE2 is one of the things that our ibuprofen is kind of preventing secretion of. So it tends to be kind of used as a gold standard inflammatory marker. And what was really interesting, so this is kind of our odds ratio and 95% confidence interval for each of these in some univariate modeling. So essentially, we wanted to see how predictive is our lubricin to total protein ratio in terms of predicting if this horse falls into a healthy or osteoarthritic category. And what was really interesting, so all 3 of these were predictive of osteoarthritis disease status, but both lubricin and gelsolin were better predictors of disease status than PGE2, which is right now one of our gold standards. And when we put all 3 of these into a multivariate model, it did even better than any of these alone. So right now, we don't tend to use soluble factors like these a ton in terms of diagnosing osteoarthritis. And what this suggested to us is PGE2 is important, but there's probably other proteins in there that are better predictors. And when we combine things into, a panel of 3, 4, 6 things, we might be even better at predicting if this joint is osteoarthritic or not. And like I said, right now, lubricin and gelsolin are just the only 2 out of that group that we can actually measure. But, you can see, so lubricin is kind of down here, increased, but certainly not the highest. Gelsolin's here. If we could start to be able to measure some of these things up towards the top, they might be even better. So that's kind of getting at the protein side of things. And I was going to say, I'm going to start talking a little faster because I get sidetracked. So the other thing I wanted to look at in horses with naturally occurring arthritis, that kind of got at the protein environment. But I'm also really interested in what the cells are doing. So macrophages, we talked a little bit about macrophages at the beginning. Macrophages are really cool cells. So when we think about them with pathogens, these are one of the cells that can eat bacteria, eat viruses, eat dead cells, things like that. And so this idea of macrophage polarization was first described in 2010. So this is a still very evolving field. And what we have are what we call these alternatively activated macrophages. These are called M2 macrophages. And these are more of the homeostatic, they're kind of maintaining the status quo. They're the ones associated with tissue healing. So, in that first chart, when you were seeing kind of where all of those tissue resident macrophages, kind of how they were contributing to just normal function, those are primarily what we'd consider these M2 macrophages. But then we have these classically activated macrophages, or M1 macrophages, and these are the ones that we think of as pro-inflammatory. These are the ones that are going to be eating pathogens. They're going to be secreting proteins to kind of bring other cells to the area. They're the ones that when we think about inflammation, those are the ones that are there. And we can identify these different cell types based on what kind of proteins they're secreting, as well as what kind of cell surface markers they have. So all cells will have proteins on their surface, And we can kind of distinguish some of these different types by what cells are on their surface. So that's what I'm utilizing, is these cell surface proteins to kind of identify these two types. The other type of immune cell that I've been looking at, and this was a little bit of a, we weren't really expecting to find much there, but it's turned into a very interesting part of the story, are T cells. So these are a part of the adaptive immune system. They're a little bit more specific in how they respond. Our CD4 T cells are considered helper T cells. So these, when they come across a protein that they recognize, these guys mostly secrete different proteins to kind of activate other cells in the area, kind of modulate the response of other cells. Versus our CD8 cells, these are the ones that, especially when we think of like viral pathogens, these can actually identify a cell that might be infected or identify, you know, this protein and actually go ahead and kill that cell. So they're kind of the big guns. So for this part of the study, again, taking naturally occurring osteoarthritis, evaluating the cells both in the synovial fluid, which is a very small number of cells, but a very important population of cells, as well as in the joint capsule itself, and doing this technique called flow cytometry. And flow cytometry is really cool. So you can take antibodies that have fluorescent tags and label the cells. So we can have one against M1 macrophages that'll be blue. We'll have some antibodies against M2 macrophages that'll be green and yellow. And we can put them through this flow cytometer, and essentially this flow cytometer separates the cells into individual, it's one cell per droplet. So as it's going through the lasers, it can say, okay, this one cell, it was this size, and it carried a blue marker and a yellow marker. So we can really kind of get down to the nitty-gritty of which cells are carrying which markers. So this is just kind of some of the readouts that we get. So you can see here, like these are negative cells here. This is a population of positive cells. So we can separate them out like that. And we were looking at, again, like I said, kind of the macrophages and the T cells. Most of this work has been done, so there's some literature in humans and rodents, but very little in horses. So what we saw, so this CD86 marker is a marker for those pro-inflammatory M1 macrophages. And this joint score along the x-axis, this is essentially a score of degree of osteoarthritis. So higher scores, more osteoarthritis. So what we're seeing is an increase in our M1 macrophages with worsening osteoarthritis in their synovial membrane, which makes sense. And this has been previously described in rodents and humans, but not in horses yet. But what's really interesting, and when this idea of macrophage polarization first came along, people tended to define it as cells were either M1 or M2. And the more people have started to study macrophages and get frustrated with them, the more we've realized that there's a lot of gray zone between these different subtypes. And that's what we're seeing here. So this CD163 and CD206 are two markers that are traditionally thought of as M2, or kind of those homeostatic macrophage markers. And while we didn't see, so in a lot of the human and rodent literature, they'll see increases in the M1s and decreases in the M2s. We're not seeing the decreases in the M2s, but what we are seeing is more cells essentially double labeling, so labeling with both M1 and M2 markers. So it's likely that these cells aren't necessarily completely converting, they're getting rid of all of their M2 characteristics and just turning into these M1s, but probably some kind of combination. So they're starting to gain some of those M1 markers, some of those M1 phenotypes, but not necessarily losing all the M2s. Here on the other side, we've got some really interesting T cell data. So the CD4 T cells have not been explored nearly as much as the macrophages in arthritis. Very, very little in horses and not much in humans either. And most of the human literature kind of focuses on these CD4 T cells. And oftentimes in that literature, they see an increase in the proportion of CD4 T cells in osteoarthritic joints. And what we're seeing is quite a promising, or quite a profound kind of decrease in these CD4 T cells, and a corresponding increase with our CD8 T cell population. And the CD8 T cells really haven't been explored much at all. So this is really cool and very exciting, and I'm excited to see where else it goes. But yeah, immune cells are really cool. So now that we've kind of figured out what we've done or what happens in naturally occurring OA, now we can kind of take those different cell types and say, okay, can we break these down further? And this is where some of the benchtop experiments come in really handy. So we can separate out our macrophages, we can separate out our T cells, and look at exactly how those are responding to different stimuli. So these experiments are still ongoing, but that's exactly what we're doing in the lab setting. So we're separating out macrophages. We can stimulate them with some proteins that we know are very typical in osteoarthritic joints. So one is IL-1 beta, is a very pro-inflammatory protein. Another one is TNF alpha. So we can stimulate these cells and essentially kind of try to create an inflammatory joint, but in a petri dish. And we can treat these cells with some of our typical osteoarthritis therapeutics. So steroids being one of the most common things that we use in horses and people for treating osteoarthritis. And oftentimes we put that directly into the joint. So we can stimulate these cells and treat them and see how they respond to those different kind of stimuli. And what exactly, so one thing that with steroids, we know that symptomatically it makes people feel better, makes our horses feel better. We know very little about how the cells actually respond to those steroid treatments. So now we can break out our macrophages, we can break out our T cells and see exactly not only what our stimulus is doing to those specific cells, but what our treatment might be doing to those specific cells. And we can use things like flow cytometry. We can measure some of those secreted proteins. So, all of these cells, when they get stimulated, they'll secrete different proteins. We can see kind of how they're secreting, how much they're secreting. And once this, kind of benchtop experiment kind of setup is optimized, we can put a million different treatments on it and make it very simple to see exactly how these cells are responding to different stimuli. So ultimately, right, we want to learn a bunch, and the in vitro experiments come in really handy in terms of kind of breaking down the system and figuring out what the different components are. But ultimately, we want to be able to bring it back into our patients, right? And in vitro experiments are great at learning those nitty-gritty details, but ultimately, it doesn't matter what the macrophages or the T cells are doing alone necessarily, because they're all going to be mixed together in the joint. All of these things are going to be interacting with each other in the joint. So we can learn a lot of the details in the benchtop, but really bringing it back to the full animal is really important to really learn kind of how these things are functioning. So we use an experimentally induced osteoarthritis model. So in these horses, we create this small chip fracture within we call it their knee. It's equivalent to our wrist. So this chip fracture is a very common injury that we see in horses. And one of the big problems that we see with this type of chip injury, this type of fragment injury in horses, is they don't get that lame from it. So it's really hard to diagnose these horses early. Unfortunately, it does cause osteoarthritis, usually 2 to 3 months down the line. And unfortunately, oftentimes we don't see these horses until they've already got the osteoarthritis. But with using this model, we can take samples from these horses at weekly intervals and see how these cells and how these proteins are changing over the duration of this development of osteoarthritis. So we create this chip and then we work them on a treadmill, and that's one of the nice things with experimental models is you can control all of the variables. So our horses are all age and breed matched. They've all got a very kind of specific exercise regimen. And that's one of the problems kind of with naturally occurring OA is you've got different breeds, you've got different ages, they're eating different things, they're exercising at different levels. There's a lot of confounding factors. In an experimental model, we can reduce a lot of those confounding factors and really kind of get down to asking a more specific question. So in this group of horses in particular, we're testing the use of a viral gene therapy vector. So this gene therapy carries 2 anti-inflammatory proteins. And these proteins have both been tested individually in primarily rodent models. We're seeing if this combination of 2 proteins can improve or reduce the severity of osteoarthritis. And the gene therapy vector is really interesting. So a lot of our intra-articular therapeutics, most of them, if you kind of measure how long they stay in the joint, most are gone in a matter of days and sometimes even hours. They don't stick around long. With a viral vector, it's actually going to get into those cells and induce those cells to be producing these proteins. So it has the potential for sticking around a lot longer. So this is an ongoing study that we've got going on right now. So we've kind of brought it full circle at this point. Like I said, there's definitely pros and cons to all of these different methods. And ultimately, myself as a, kind of a clinician scientist, need to kind of utilize all of these different methods to ultimately be able to bring it back and kind of put all the pieces back together in our patients. And that's all I got. Any questions? Yeah.
I was just curious about the population of horses you used for the proteomic data.
Yeah.
About ages and breeds and things like that.
For sure. Great question. So they were all horses with knee arthritis. So we did limit it to a single joint. But we definitely did. So the bulk of them were 2 to 6 year old thoroughbreds, because those are the horses that tend to get knee arthritis. But that being said, we certainly did have a good number that were older as well. For those older ones, so the healthy horses are oftentimes either research horses just in our teaching herd. Thankfully, it's just synovial fluid, so we can take it in a fairly minimally invasive manner. Or horses that were euthanized for reasons unrelated to carpal arthritis. And so for some of the older ones in the group, we try to match a little bit. And thankfully, ultimately, our healthy and OA groups ended up we didn't have significant differences in breeds and ages, but that's a great question.
In some of your figures, you taught there was a determined joint score.
I can go.
I was curious, how do you determine a joint score?
Yeah, so there's lots of different scoring systems out there. So there's radiographic scoring systems. So if we're doing a study with live horses, oftentimes people will use radiographic scoring systems. These were all horses. So the diagnostic lab at Cornell has they have a program with the New York State racetracks that any racehorses that die or are euthanized on New York State racetracks have to go there for a necropsy. So it's a good surveillance. I mean, they use it primarily for surveillance, why are these horses dying and what can we do better to prevent them? For me, it's a good opportunity to utilize these horses for things beyond just learning how we can prevent breakdown injuries. And thoroughbred racehorses do have a high incidence of arthritis. They're high-level athletes. So these joint scores are all based on gross pathology. So actually opening the joint, looking at the cartilage lesions, looking at wear lines, looking at bony proliferation and joint erosions and things like that. So that's where this joint score comes from. But you'll see everyone kind of comes up with their own depending on what they're looking at. Yeah?
So correct me if I'm wrong, but you did single cell sequencing?
So this was flow cytometry. Yeah, so I was going to say, so that's actually part of the plan for this experimentally induced OA group. Because one of the problems, so we are seeing some differences based on cell surface markers, but the more people kind of learn about macrophage polarization, the less clear it is what the cell surface markers are necessarily doing. So yeah, that's a great point. So we're planning on doing, so there's a relatively new technique called single cell RNA sequencing that we can actually label the individual cells and then see what proteins they're about to produce by looking at the RNA level. And that has kind of changed the game for exploring these immune cell populations. So macrophage polarization, just based on cell surface markers, we've got about 5 groups. So our M1s are kind of always M1s, and there's about 4 M2 groups based on cell surface markers. When you look at RNA-seq data, there's about 17 different groups. So yeah, so that's part of our plan with this experimental group, is to do some single cell RNA-seq on them.
I know it's super expensive.
Yeah. Yeah. Yeah, we just got a grant funded to do some of that on some synovial membrane, so I'm really excited to see that. Yeah.
I do have one other question for you.
Yeah.
So you were talking about you had your 2 pools of samples that you were looking at. One was the healthy, and the other one was the one that already had osteoarthritis. In the beginning of your presentation, you talked about osteoarthritis in almost stages of it, where it goes from okay to we can't fix it anymore, it's a done deal. So the horses that you took the samples from that had the osteoarthritis, where were they in the stage, and would that change the biomarkers that you saw?
Absolutely. And in the interest of time, I didn't put kind of all of that data in there. So those horses, we did give them radiographic grades as well. So they had they essentially got split into 0 being our healthy, 1, 2s, and 3s. For the horses undergoing proteomics, they were all grade 2 horses, because we wanted to standardize the proteomics, as much as we could, because we didn't want to get too much variability with, having some that were very low, some that were very high, in terms of disease spectrum. Really interestingly, when we break it up to radiographic grade for a lot of those soluble markers, and we've seen this over a lot of different soluble markers, the grade 2 horses seem to be the most different from healthy. And the ones with really severe disease, kind of those end stage grade 3 joints, actually start trending back towards normal, which is really interesting for a lot of different soluble markers. So PGE2 was like that. Lubricin is pretty consistently like that. Argelsolin, we also saw that. And other groups have seen this as well. And one of the ideas is, with those really end stage joints, everything is just so fibrotic and damaged that, we suspect that some of those cells are actually, we're kind of losing potentially some of the really inflammatory phase, and everything is just kind of shutting down at that point, because you've got so much fibrosis and just so much damage that it's almost kind of creating a quiescent, spot. So all theoretical at this point, but pretty consistently we see kind of those grade 2 horses as being the most different from healthy. Yeah?
Okay, last question, and this is more of a practitioner question than research question, because we cover this in biochemistry quite a bit. And either human or animal, there's supplements to support joint health. So cosequin and horses, glucosamine, chondroitin, HA. In your opinion, when are those supplements beneficial versus when are they just useless?
Yeah, so it's tough. So there's a lot of different products on the market, all with different bioavailability. So when I was in practice, I'd get this question a lot. I think early, before, they're not going to rebuild cartilage. And so, yeah. But I think, like, the athletic youngsters, to try to kind of help maintain healthy joints, I certainly think, unfortunately, the ones that have some research to back them up also tend to be the most expensive. So a lot of times what I'll tell people is try one of the ones that have some science to back them up for 3 months. If you notice a difference, if it seems to be helping in 3 months, awesome, keep going. If you don't notice a difference in 3 months, it's probably not going to help. But I certainly think they probably have potentially more of a role before, in the healthy ones before we have joint disease. Yeah. Yeah.
Any other questions?
Yeah.
you see that within your population of horses?
That's a great question. So we will sometimes surgically fuse joints with severe disease. Horses are tricky when it comes to orthopedic things. And so, yeah, so we certainly will do that surgically sometimes. It's not nearly as common as in people. And in people now, there's so many options for joint replacement that, fusion is definitely becoming less seen. But certainly some of our low motion joints, as that arthritis progresses, they'll actually get pretty close to fusing on their own. So hock joints are one in particular, lower hock joints, really common spot for osteoarthritis. And oftentimes those the ones with more severe radiographic changes will actually be less. So people have looked at, radiographic changes in hock arthritis with clinical signs, and the radiographs and the clinical signs don't match up at all, because it tends to be those horses where you're starting to get the inflammation, you're starting to get some of that bone change, but they still have a decent amount of motion in that joint. Those are the ones that are most painful. Once they start laying down some of that bone and all that cartilage is gone and they're essentially healing that like a fracture, they actually can get quite a bit more comfortable. So like those lower hock joint horses, pastern joints are another one. Sometimes fusing them will get rid of the pain. They don't need a whole lot of motion there anyway. So, good question.
So with that, we're at time, so let's thank our speaker. If you guys would like to stick around and chat, we'll go outside and do that.
Thank you guys for having me too.